I'm so glad to see you all on such a dreary day, but I'm delighted that you're joining us this morning. I'm especially grateful for our four wonderful panel participants. I'm just going to give you their names and they can wave because part of what we're doing is they're going to do their own introductions. So I have Julie Bilodeau with Crossover, Tyler Agee, Tracy Causey, and Karen Kimsey will be your panel speakers. As you are well aware, issues of accessibility, cost, and treatment in healthcare affect all of us. While many of us were accustomed to a fair amount of predictability in how we access healthcare services, the one big, beautiful bill passed in 2025 has resulted in significant cuts and policy shifts which change much of what we've been used to in healthcare delivery. We're pleased this morning to present a conversation with all these wonderful individuals who understand and are responding to the changes in the healthcare funding landscape. So to start with, I would like to ask our panelists just to introduce themselves briefly and how they came to focus on healthcare, especially in the areas of accessibility and funding. And you're each sharing. So Tracy, you're closest. We'll start with you.
I think I turned it on. Can you hear me? Good morning to everybody, and it's great to be here. I am Tracy Causey, and I am very proud to say that I'm serving as the CEO for Capital Area Health Network. The network here is we reside here in Richmond, Virginia. Of course, we have three locations. Our stalwart, the very first one, is in the East End, and it's called the Vernon J. Harris Community Health Center. And then we have one on North Side, which is a North Side Medical Center, and of course, we have a pediatric medical center over at the St. Mary's Hospital. We also have a mobile unit. You may have seen that thing running around here. You know, that's one of my little toys. I will tell people that I really love the mobile unit because you can get almost anywhere with that thing. And since I'm talking about the mobile unit, I have to say this. I was surprised to see Dr. Whitehurst Cook. I did not know she's a member of this congregation, and she's actually our physician on the mobile unit. And very proud to see her this morning. So good to see you, Dr. Cook. All right. I think the question is that how did I get here? Well, I am originally from Mississippi. And if you know anything about Mississippi, it's a very rural state. Of course, we have a couple of big cities around there, but I'm from a very rural town called Tylertown, Mississippi, which is about 90 miles north of New Orleans. And so, yes, we are gearing up for Mardi Gras season right now down there. It's going to be a fun time. But as I was growing up, one of the things that was lacking in my hometown was adequate resources for medical care of any type. Healthcare was just not one of the things that the county or the area invested in, apparently. And so we did have a hospital, but not very many private practices or places for people to go for healthcare. So during my childhood, one of the things that me and my brother, my older brother, said that we were going to bring medical services to our hometown. Unfortunately for me, I decided to go into a different direction in college, and I wanted to be a scientist. So I want to be a researcher in biology, a biologist. But my brother, on the other hand, he's a pharmacist right now. He just retired out of the army, a colonel. He's one of I have to tell this story now. So he's of course African American. There are only 12 colonels who are pharmacists. He's one of the 12. And so we're very proud of that. He just retired, of course, and he's working in northern Mississippi. But one of the things that we've always wanted to do was make sure that we took care of people. There was something that my father and my mom instilled into us. Make sure that you take care of your neighbor. And so here I am. I've traveled a little bit. I was in the Air Force, and I've seen a lot of things, a lot of bad things, and a lot of need. And so one of my life goals was just that I wanted to give back a little bit. And so it kind of propelled me into this direction. When I was in the Air Force, I got into hospital administration, and then I felt a need for a little closer to the ground where people actually lived and worked. So I got into the clinics of the hospital system, and here I am today, CEO of Capital Area Health Network, giving back to the community. Want to make sure that we have access to quality care regardless of who you are. We don't care. One of our things is that if you make it through our doors, we're there with open arms to take care of you the best that we can.
Good morning. My name is Julie Billadew, and I'm the CEO at Crossover Healthcare Ministry. And just a few things about Crossover. We are a free clinic, a free and charitable clinic, unlike Tracy, who's at Capital Area Health Network, which is a federally funded health center. So these are really kind of the two different kinds of safety net providers in the community. Um, and so I was born in the big town of Warsaw, Virginia. Who knows where Warsaw is, right? Yay! Proud graduate of Rappahannock High School out in Warsaw. And I was here in Richmond um, working for Circuit City. Who remembers Circuit City? Yeah. So my story is really different than Tracy's. I think mine was a little bit more of mine's really unexpected. So I was at Circuit City. I left Circuit City back in about 2000. I will say the stock was doing really well when I left. Just want to say that. But my boys, I had two young boys. I made the decisions to stay home for a couple of years with the boys. And then when I wanted to go back to work, I really thought about what do I want to do, and crossover kind of came onto my radar. It was unexpected, but it was really a great opportunity for me to have two passions that intersected. One was being part of the faith community and working for a faith-based organization, and the other is to address healthcare because a couple of things I believe about healthcare. One is I believe that every person deserves access to healthcare, no matter who you are, where you're from, what your income is. And I think one of the tragedies that we face today is that people can't afford to go to a doctor or they don't take their medicine because they don't have health insurance. The other thing I really believe, and is why I'm at Crossover, is I believe that your health is the foundation on which the rest of your life is built on. I think that if you don't have your health, you can't keep a job, you can't go to school, you can't parent, you just can't do anything if you don't have your health. And so I work really hard, as does everyone on the stage, to really help folks in Richmond build that foundation of health that they can build the rest of their life on and be successful and do what they dream about doing to help them fulfill their dreams. And so Crossover was founded in 1983. I came to Crossover in 2003. Tracy and I both went to our organizations in 2003. We just figured that out. Um, in 2003, I thought, oh gosh, I'll be there for about 2 years. And here I am, 22 years later. And so, what has been so rewarding is watching access to healthcare evolve and watch crossover evolve. We have two locations. We have the Cowardin Clinic that many people are familiar with down on Cowardin Avenue. And then we have a clinic that opened in 2005 in Western Henrico. Um, I don't know how many of you know this, but when I came to Crossover in 2003, we actually had a small satellite clinic at St. Paul's Episcopal over in the annex area. And we were here every Wednesday. We sent a team and we saw folks at St. Paul's. And when there were some space issues and things like that, but we consolidated. But we've had a long-standing relationship with St. Paul's for many, many years, and we're very grateful for that. Um, and so we take care of two groups at Crossover, low income uninsured, and then we take care of folks with Medicaid. And we do that through a comprehensive set of health services that we offer. We offer, primary care, obstetrics care, pediatrics. We also have a dental clinic, an eye clinic. We offer HIV care, behavioral health, and pharmacy. And we have a licensed pharmacy. One thing that's a little different, I think, about our two models is that we provide about half of our care through volunteers. So last year at Crossover, we had 550 volunteers. And so volunteer nurses, volunteer physicians, you name it, we have volunteers doing it. And so many folks here volunteer at Crossover, and we're really grateful for that. But thank you for having me this morning. Yes.
Good morning, everybody. My name is Karen Kimsey, and I am a healthcare consultant in the system. But prior to becoming a consultant, I actually spent most of my career in healthcare and Medicaid and state government, to be exact, about 27 years. And I started off, though, and it was a calling for me, like many of us here, I grew up actually in Tappahannock, Virginia, very rural area, and that's why I was like, woot woot, across the river. Very small community, and I also grew up uninsured, as many individuals did where we grew up. And so I became keenly aware of what health looked like and poor health looked like growing up as well. And so it became a huge passion of mine, especially among the elderly. So I'm a gerontological social worker and ended up, doing an internship at Medicaid, fell in love with health policy, never looked back. And I was supposed to be a clinical social worker, but I ended up doing health policy instead. And in my years there, I was just devoted to it, loved it like every day, and had a beautiful opportunity to create programs helping to serve people in their communities, people with disabilities in particular. And wanted just a huge shout out to St. Paul's because I used to come here at legislative session every year and meet with all the people with disabilities who are advocating for healthcare and help update them on what they need to do. But you all have always been very present in supporting individuals and advocating for their health. So I wanted to thank you for that. But some of the bigger pieces I did is helping advance supports for people, but in particular addiction and treatment. I had a brother who died of an addiction, and I was very blessed to be one of the primary people helping to create that in Virginia. So it's a beautiful pay it forward, and it affects millions. And for the Medicaid program, it served around 2 million people. Now I think it's a $26 billion year budget. But during those course in time towards the latter year, really helped with people who are eligible for both Medicare and Medicaid learn and understand what their benefits are. It's very important, like we were talking about, not just knowing about what's eligible for you, but how to use them and making sure people really do have health. And I agree with you, everybody should have access to health care, period, no matter how much your income is. And so helping towards last piece, one of the biggest pieces I did in partnership with communities here, and you are such fantastic partners in the Medicaid benefit, is expanding it to childless adults, young adults, and in between the age group of 19 and 54. And so that 64, excuse me, just tired this morning. We've had a busy weekend, as you know, but expanding it to 400,000 people prior to COVID hitting, and then I was the director through the agency through COVID. And when we had 700,000 humans, souls added to the mix, and covered them. It was really a safe haven for people during that period of time, and it was a true honor to support it. And when Governor Youngkin took office, I was transitioned out, and that's how I entered the healthcare market this way. And I primarily work with states in helping them with their healthcare programs, as well as communities and nonprofits. And so this is where I am, and it's a real honor to be here with you today to talk about the trends changing in this area.
Well, good morning. My name is Tyler Agee, and I'm the Director of Community Health for VCU Health System here in the Commonwealth. For those who may not know, VCU Health is the largest safety net health system in the Commonwealth, and I'll get into what that means a little bit later and the implications ahead. We have our flagship medical center downtown, right across the street. VCU Medical Center, a children's hospital of Richmond next door. And then we actually have two rural hospitals that are connected to our system, one in Tappahannock and then one in South Hill, which is almost to the North Carolina line. I actually started my career focused on physical therapy and got into, I think, my second class of anatomy in college and decided this is not for me. I'm going to let the clinical experts move in this direction. But at that time, the idea of the social drivers of health and this whole concept of only about 20% of your health is impacted by the actual clinical care you receive. The other 80% is made up of where you live, what's your education, what's your income, what type of food do you have, what type of housing do you have, and all the social drivers of health. And that really steered me in a completely different direction into health promotion and how do we support communities and patients to not only receive the right clinical care that they need, but also have those wraparound support services. And so in my role, I really lead our social needs strategy for the health system. And as folks come to us for clinical care, making sure that they're connected and leaving the hospital with food, with the right housing support, with the right medication support and funding to support that for their total health. So it's been a privilege to work with many folks up here over the last few decades, and really glad to be here today. I will just mention I spent about a decade of my time before coming to VCU Health running two charitable clinics in the region. One was, and still exists, the Bon Secours Caravan. It's a mobile unit, partners with the faith community really across the whole Richmond region, and primarily focuses on undocumented and Medicaid recipients. And then St. Joseph's Outreach Clinic, which no longer exists, but was a partnership with St. Joseph's Villa off Brook Road. That clinic really cared for low-income Medicare and Medicaid and uninsured individuals in our region. So have that experience I brought into this role, into the health system, and really thinking about how do we wrap around care for folks moving forward into the next year or so.
Well, thank you all. So my first question is, what is the current impact of the one big beautiful bill? How does that play out in your organization or in your area? And how do you anticipate that the future cuts and changes that are mandated in that bill, how will they affect you? And this time we'll start with Karen.
Well, it has a dramatic impact. And so we're going to talk about Virginia specifically in our conversation today, but some of the work, and I didn't mention this, but I just had the very distinct honor and privilege of serving as a co-chair for Health and Human Resources policy for the new governor, Spanberger, and so had an opportunity to meet such wonderful people in the community, such as folks here and Tracy on the team, and all these folks to hear about what is important. And this law has a significant impact. I'm specifically going to talk about Medicaid related to this, but there were some requirements put into place in the effort to realize all those cost savings they were looking for. It has had a dramatic impact on safety net programs in particular and protections around safety net programs. And the bigger one I see as a larger safety net program is Medicaid. So some of the components, and we were just talking about how the Commonwealth took a little time, but very proud of them to add that very critical benefit. And by the way, during that period of time, also added dental, which was fantastic. And I was very privileged to be there when that was added too. Such a critical component. And these impacts are coming where they're saying now to these individuals who are enrolled in this benefit, it's basically they're targeting childless adults. So it may not just be you hear about Medicaid expansion benefit people in that expansion. That means people who make about $22,000 a year. Think about that. So they're targeting people who only make less than $22,000 a year. The requirements are, if you are in this category, in this group, one, it used to be annual determinations to make sure you were eligible for health care. Now they're making it every 6 months.
And states sometimes struggle with their data and their processes to get that done because you have 2 million human beings on the program. So imagine having to, reevaluate 500,000 of them every 6 months. And not only are they having to do that, on top of it, they're going to have to prove that they're either working, that they're volunteering, or they're in school. Now, there are some groups of individuals who are exempted, and we're very grateful to see that. Virginia did have some experience preparing for this Medicaid a few years back when in 2018 there was a directive to make Medicaid move towards what are called work requirements or community engagement requirements. And that's how they're framing it. So in order to receive health insurance and Medicaid going forward, starting in January of 27, you have to be proving that you're employed or that you're volunteering or that you're in school unless you are exempted. That includes, and are folks okay? Do you want me to give a tiny little list just to kind of refresh it? Okay. I don't want to just make this too detailed for folks, but if you're pregnant, you are exempted. You're also exempted if you have special medical needs, if you have like a substance use disorder, for example, if you have a complex medical condition, if you've been identified as disabled. So that's really important because not everybody sees themselves that way, but it's going to be important going forward with you all and helping educate people what those exemptions look like and how you can help them with that. Disabled veterans are excluded. Parents, guardians, or family members of children under age 14. Now notice I didn't say disabled adults. People are caregiving for disabled adults. So that's a particular group folks are very concerned about, and I did want to float that. The tribes, individuals who are affiliated with tribes, Native Americans, are exempted. They have their own health insurance system that they leverage as well. And people who have recently been released from incarceration. So more information is coming. So there are opportunities to say, yes, we don't think, these individuals don't have to prove all these things because they already meet these categories, but we think it's going to impact 500,000 people, at least. Maybe more. Those were the preliminary estimates. Prior administration would not release additional data up until this point. So it was a really tough, and I think now going forward with the folks in the system and the community and all to also make sure and identify who all these individuals are. So these individuals will have to do the regular reporting and requirements, and that, to be honest, is the biggest problem. So they're concerned about people knowing, one, there's been a huge disillusion of trust in government and believing in public health. And so there's a lot to do to rebuild that trust coming from information and sources and who to believe. So when a letter comes to say, hey, can you please renew this? Somebody may not always open that letter. They may not always believe the emails they receive. They may not just open things. And so there's a huge effort underway because people are going to have to work to, evaluate their eligibility as well as prove these requirements. And so these are some particular pieces that we're going to have to be paying attention to. The state is going to be putting in place, but the real losses are coming because they know that people simply won't understand how to fulfill this. And so that's where there's going to be a lot of effort going forward underway and working with strong community partners such as yourselves in order to help people understand what that looks like and what it means going forward, and then to help them with actually fulfilling those requirements. Now, there are additional requirements, additional changes coming down the pike that are in the tunes of hundreds of millions of dollars of impact, cuts to private hospitals, hospitals in general, and how those payments are made, and other different payment structures that Medicaid programs have leveraged over the years to help shore up programs to cover uninsured individuals that are now being cut. That means state and local agencies are going to have to look at other creative ways to help cover people or insure them. So there are some changes coming down the pike, for example, around hospital cuts to hospitals and how they're paid. There is some hope that with congressional changes coming forward in the November election, that some of those changes might come, that they may find a different way to find those cuts other than the targets that they're looking at. But right now, it's all in place, scheduled to happen over the next 10 years. Within 10 years, all those cuts will be phased in. It will impact millions of individuals across the country. And they will lose coverage, as many as 11 million. Also, people have lost their ACA subsidies, so their health care premiums are exploding. And that means they may have insurance, but they may not be able to afford to use it. They may not be able to afford to pay those co-payments or those premiums. And those changes to the subsidies, if you've been hearing in the news, went into effect January 1st of this year. So some people may not even be aware of that. And I'm going to
Thank
turn
you.
it over to somebody else. Sorry, I get a little passionate about it.
Tyler, go
No,
ahead.
that we're grateful to have an expert on some of those elements, and you touched on several patient populations that we're really concerned about. I'll just go back to VCU Health being the largest safety net health system in the Commonwealth. VCU Medical Center cares for the largest percent of Medicaid patients in the state. And so as folks we anticipate falling in and out of coverage don't have that paying source, how can we, we're going to continue to care for them, but what are the implications to that from a financial perspective for us, but also for the patient to fall in and out of having a visit covered by Medicaid and then their next visit not covered because they're uninsured. So we've been looking internally at some of our financial assistance policies and how can we make sure that the folks we think may fall in and out of coverage can be covered to some degree by VCU Health System, and exploring that. I wanted to bring one number to a comment you made just a second ago. This is from the American Hospital Association, but Virginia hospitals could lose up to $26 billion over the next 14 years due to Medicaid cuts. So $26 billion just for Virginia hospitals. That's a significant challenge ahead of us. And what does that mean for care? What does that mean for our ability to pay our staff? What does that mean for our ability to buy the new equipment that we need and stay on top of the changing environment? What does it mean for services that may already operate at a loss? And just a couple other data points from a rural health perspective and the implications to our two rural hospitals. Again, data from American Hospital Association, nearly half of rural hospitals operated at a financial loss in 2023. So that means half of our community hospitals that are sometimes the only source of healthcare for folks living in rural communities are underwater and have to be supported by these programs. 92 rural hospitals have actually closed their doors in the last 10 years, and that trend continues. Critical service lines like behavioral health, pulmonology, obstetrics, burns, and wounds operate at a negative margin. We can't simply cover those costs. And then nearly half of all rural births are covered by Medicaid. And when you look at our children's hospital, that number is more like 60% are covered by Medicaid. And so, we're anticipating that into the future. Just one other comment around kind of the sunsetting of the Affordable Care Act expansion population. So these were, as you may know, kind of advanced financial assistance for folks that were accessing healthcare through the marketplace during that expanded Medicaid time, and over 90% of folks that were accessing healthcare through the marketplace qualified for these subsidies. And so now that those subsidies don't exist, what does that mean for 22 million people in the US that were relying on this subsidy to bring down their monthly premiums? Again, falling in and out of coverage, and really thinking through what does that mean for folks as they likely end up delaying care, not being able to afford care, and then ultimately coming to the emergency room, which is what we don't want in a more fragile and sick state. So I think those are some of the things we're really thinking through into the future. The last comment I'll make is also, as an academic medical center, there's several funding implications for our students and reimbursements for medical professionals and going through their career. And so we got to think about what the future workforce looks like and how do we make sure we continue to train and make it accessible for someone to seek the degree that they want and need to fill for and plan for our future workforce needs. So some concerns there that we're also working through.
All right, Julie.
All right, I'll try to follow those two. Um, First of all, I just want to explain a little bit about crossover and how we work from a day-to-day perspective. Um, I said earlier that we take care of two groups of folks. We take care of low-income uninsured, and that's the majority of our patients. And then we take care of patients with Medicaid. But to understand that, whether you are on Medicaid or whether you're uninsured, really makes a difference in terms of the resources that we have available for you. I wish I could say they're the same, but they're not. So, for example, if a patient has Medicaid, they can only see a provider who's employed. Our uninsured folks are much more likely to see a volunteer. If a patient has Medicaid, if they need a subspecialty appointment, we refer them out into the community, into the Medicaid provider network. If they are uninsured, they see a subspecialist at crossover, and we are incredibly blessed to have about 15 subspecialties in house. And then we refer out to a network in Richmond called Access Now. And then another example is on the pharmacy side. If you are on Medicaid, you go to your local pharmacy and get your prescriptions filled with a very specific formulary. If you are uninsured, you get your medicines at crossover. And so I tell you that because I want you to understand what we're about to go into. We're about to go into a period where we have a large group of patients who are Medicaid who aren't the best at navigating the system, right? They have health literacy issues. They often don't have a stable mailing address. So what we're going to see is we're going to see patients that might come in for one visit, they have Medicaid, they come in and they check in for their next visit and their Medicaid is no longer active for all of the reasons that you guys just discussed. So we have to go like this. Like we had planned for this, care plan. Now we have to go over here. And then potentially the next time they come in, they're back on Medicaid, so we have to go back over here. And that just creates a tremendous sense of discontinuity for the patient and a huge administrative effort for the outpatient clinics that are seeing them. And I think that's what we're going into. We're going into people who are in and out of Medicaid and they're getting, like this with like who they go see. It becomes very confusing for them. And so I think it's going to be a tough time from that perspective. We're also, I think most people would say we're about to see a very large increase in the uninsured. And I'm going to tell you, I don't think the Richmond safety net is prepared for that. Most of us are at capacity. And so we're frantically looking at ways that we can um, increase our capacity to help our neighbors. Um, it's bigger for us than Medicaid. Funding, you ask any free clinic person what's going on, and we always go back to funding. 75% of our revenue, because of the way we're structured, comes from philanthropy in the Richmond community. So as we shift over to having a higher percentage of uninsured, that means we're going to have to raise more money from the community. Not that we make money off of Medicaid, but we have to subsidize care on a much higher percentage for the uninsured patients. So that really increases kind of from our perspective, the amount of money that we need to go raise in the community. Many folks know there have been some severe cuts, crossover specifically. The Virginia Department of Health came in back in May and they ended our HIV funding. And they gave us 8 days notice. They took $925,000 away from us and gave us no notice and really very little help on what to do to care for the patients. They won't fund the labs that they need. They really said, we're just not going to help you anymore. You're gone. So we are still providing care for folks living with HIV, but it's not through the Ryan White program. It's through the philanthropy, and many churches came through for us to help us with that. A large percentage of patients that are uninsured are newcomers to our country. So I do feel the need to address that just a little bit. Um, we have seen spikes in anxiety, depression, fear, not just for people who might be what we call undocumented, but people that are here legally. They're just very afraid. They are afraid of what is happening. They are very afraid of what might happen to their friends and their neighbors. And that's not just our patients, that's our staff, and that's our volunteers as well that are afraid and feeling that way. Um, you know, we are in a community where ICE is here, right? We know that. So there's fear. We have seen some of our patients leave the country, and we know that. We also see an increased no-show rate because people are, some of our patients don't want to leave their homes to come to the doctor. They're scared of what will happen. We've tried to pivot to telehealth when possible, but it is a challenge. Working with the community, and then people are afraid. Our refugees, we do a lot of work in the refugee community. They are very afraid that they are going to lose their Medicaid, and they're very afraid that they are also going to be targeted. So a big sense of anxiety, a lot of stress. Um, it feels really chaotic with our patients and our employees. So
So, before I start, I'd just like to say that that they have really characterized a lot of the issues that we are facing with this big beautiful bill that we're talking about right now. And before I get too far into this, let me introduce someone to you guys because she's a great resource to us, and her name is Tracy Douglas. Tracy Douglas, she is the Virginia Community Healthcare Association's CEO. And she's the person that organization is the organization, association that we federally qualified community health centers refer to, depend upon, to help answer some of these questions that we're having and work through some of the issues that we are experiencing. And we depend upon Tracy and her team to connect us to people like you, to our state legislators, the community leaders, those folks who can really stand up and support the efforts and the needs that we are experiencing right now. So I'm going to ask her to say some words in a few minutes, but let me tell you about who we are and how we are trying to get around or get over to support this uh, the things that we need to do every day. My organization take care of about 18,000 people, 17,900 and some people in 2024. 17,000 people, right? And so we depend upon Medicaid, Medicare, other insurances, and we take care of about 17% of my patients are uninsured currently. 17% of that 17,000, they are still uninsured. Now, we have a budget of about $16 million. I have a staff of about 150 people, 155 people right now. I have 20 physicians, 20 providers, dental, mental health, and also the medical side, right? We take care of 17,000 people, $16 million budget. Every year, we face about $3 million in what is called uncompensated care. $3 million. Where's that going to come from? How are we going to make it in this time, in this current atmosphere that we're all trying to navigate? Under these proposed cuts to Medicaid, it's going to have a effect that is beyond what we can imagine. As Julie just implicated, we're going to have more people at our door needing care, more uninsured people. In one period in this country's life, we thought we kind of solved that issue a little bit with the Affordable Care Act. And we understand what's going on right now and trying to make it better. Of course, that's what we're going to say. We're trying to make that process better, but in our effort in doing that, we're going to cause more pain. It's probably going to be unavoidable pain for a lot of people. I have patients who say that I used to have my My premium set at $600 a month now is 1,300, 1,400, and we cannot afford that. And so we're going to go without insurance from the marketplace. No, they're going to forego that. And as Julie said, for the uninsured people, their services, their ability to get certain services is not going to be the same as someone else who may have Medicaid or Medicare or other insurances. So that's a problem. There's a problem that this bill potentially is going to cause if we cannot find a solution to get around those issues. Additionally, this bill is going to cut into our workforce ability to train people. As you all know, there are shortages of doctors right now across the country. Well, this bill proposes to cap cap what loans are for folks to get a loan to even afford to go to medical school. And if you know, medical school is not easy and not cheap. That's a very expensive endeavor within itself. And then to cap that and cut those opportunities to pay for that, a lot of the people who benefited from that will not go to medical school. So we're going to have a shortage. And where are those folks going to go now? Additionally, I just understand that the Department of Education, there's an effort to say that nurses are no longer considered as professionals. Wow, that's going to be interesting, right? It's going to change a lot of minds for people, a lot of great people who really want to care for this population. They're going to change their minds, and do something else. And you can't blame them because you have to be. Some of the folks are the sole provider of their families, and so they have to make a way of some kind of way. We're going to lose a lot of people through this bill, I do believe. We're going to have a lot of new uninsured people that's going to come to our offices, and our capacity is going to be capped, and we're going to have to turn them away. And our motto is that we do not turn anyone away. We just cannot do that. We will make a way of some type. But what is that going to look like? How's it going to feel to the person that we're trying to take care of? It's going to be devastating because they're already embarrassed because they have less. They have less, and we try to make them feel as comfortable as possible. We try to make them feel a part of the family. Because I tell people all the time that we are no different from the patients that we serve. We're not. We're all human. We all are a moment away from any circumstance that could switch our life trajectory at any moment. And work requirements in this bill, and some of the exemptions that Karen talked about, the one that scares us the most is the exemption for pregnancy. You know, People are going to do what they have to do to maintain Medicaid. And so if that means getting pregnant, well, watch out, you know. But where are they going to go? Where? We don't know yet. So that's where you guys come in, and we're very thankful for you for having us to talk to you about this. But that $3 million uncompensated care that I just talked about is not going away. It's going to increase. It is just going to increase. We are now getting into the season of going down the street here and talking to our state legislators and the association and the community health centers. And I know that the Free Clinic Association, we're all going to go down there and we're going to talk to these folks and we're going to ask them. And we feel good about this administration, right? Well, let me tell you something. Whether you're Republican, Democrat, Independent, I don't care. The issues are the same. How do you pay for it? How do you pay for this? We got to figure that out. It doesn't matter what side of the lane that you vote on, but you got to figure this thing out. And yeah, I think crossover may have a little more experience at fundraising than we do, but we are fundraising also now. We are just forced to do it. We have to write more grants, and we have to ask people like yourselves to support us more. Yeah, we do. We are depending on people like you to stand in the gap
Mhm. Certainly.
I just wanted to follow up on Tracy's comment, where are they going to go? Because, you know, folks don't call crossover and say, I'd like to come because they want to check up. They're in pain, they have a medical condition.
Mhm.
And when we can't see them, they go to the emergency room.
Mhm.
And that's how we're all connected, because what we end up with is a system where something could be treated in an outpatient setting. It could be treated very well at a lower cost to the community, but because they don't have that access, they go without care, and like things are diagnosed later. Um, we have strokes and heart attacks and all those things, so they end up in the emergency room. And then that's where Tyler's talking about the hospital's issues. The emergency room is not inexpensive, and so it's one of the more expensive forms of care. So then that channels into bankruptcies and medical debt, and the cycle that we get into. So that's why Tracy's question about where are they going to go becomes so critically important to us as a system. So.
Thank you all. It makes you nervous. But one of the questions I have before we turn it over to everybody else, you've mentioned fundraising. How best can we as a congregation and or as individuals, what are there things that we can do to help you? I've heard, like I said, the fundraising, I think being well informed, but are there other ways that we can actively engage to help?
So the first thing I would say is pray for us. I absolutely believe in the power of prayer. So please keep all of us in your prayers. We really need your prayers. The second thing I would say is volunteer. I really believe that anyone who is interested in volunteering at Crossover, if not at Crossover, at Health Brigade or um, Daily Planet, Capillary Health Network, but really get involved. I think that when all of the administrative components of Medicaid eligibility kick in, I think there are going to be roles available for people to help work with patients to renew their Medicaid, to, figure out how to handle the work requirement. But I would encourage you to volunteer if you are a medical professional, a nurse, a social worker, an interpreter. Um, there is a way that we can use your gifts in the safety net, and we really need you. We really need you.
Of course, I'm going to say fundraising is huge for us because you're going to think about this. Where are they going to go? Or who's going to pay for that service anyway? Because you can give money to our organization and we can kind of close that gap, or you can't, or you choose not to help us fundraise, and then you have more homelessness, you have more people on drugs. They are going to have the other pinches of the system is going to happen. And so I just want to ask that as you hear about opportunities to give, please give. I know you already do. Reach out to your friends and ask them to give. Talk to your state representatives, either at the state level and, of course, at the federal level. Reach out to those folks and let them know what we are experiencing here in Richmond and this region, and let them know that we need their support with funding and other resources that medical services require. I'm going to save some time because I do want you to hear from Tracy during the question and answer service portion of this, because she has some great ideas also on how we can connect and make sure that we close that gap as much as possible.
And I'm gonna, okay, we'll get to you in a minute.
Just gonna echo what they both said and double down on this idea that I think there's gonna be kind of this desperate need for people to have a trusted, informed community member that they can go to help navigate the system. I mean, there were some references earlier to we have a tremendous unhoused population in our emergency room today, and how does someone who doesn't have a house receive the letter to enroll in Medicaid every 6 months? Um, we there's great the foundation, Cover Virginia, Enroll VA, these great organizations, Legal Aid Justice Society, that are in the community working and educating lay people and those that are passionate to help with volunteering their time to help people stay informed and stay enrolled. And so I just would ask that you consider that if that's something that you're passionate about.
Karen, you.
Echo all these things. And just one additional piece that's really relevant, tell their stories. If you see real impacts happening to people in your communities, tell their stories. Tell them to leaders at the community level, at the state level, at the federal level. Like, people don't truly understand or realize what these impacts mean to everyday people. And so tell the stories, and that's when people start paying attention and looking up.
Thank you. Thank you all so much. This has been very informative. Tracy, if you got something you'd like to add real quick. Mhm. Mhm. And one other thing that kind of related to that is that close to 50% of the national Medicaid budget is spent in long-term care. So it affects not just poor people, but it also affects those of us who are getting whiter or grayer by the day. It is 12:30. Um, I'm sure our panelists would be glad to stick around for a few minutes and answer additional questions. But for those of you who I know need to go, I'm going to also ask you to pick up one of these Faith Calling for Action that we put together for each of these programs. So grab one, share them with your neighbors, your friends. I think really being informed is the best thing that we can do. Talk knowledgeably. This bill is anything but beautiful. So that's call. Yeah. Yeah. All right. So let's have a round of applause to thank our panelists. And go out there and make the call.
Thank you very much.